Hello, and welcome to DScPT's Continuing Education webinar series. DScPT offers webinars on a variety of topics throughout the year. The topic for today is balance, fall prevention, manual therapy, and exercise. My name is Robin Malik, and I will be facilitating today's meeting. Please note the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Dr. Scott Benjamin. He received his undergraduate training from the Michigan Tech University and his physical therapy degree from the University of Illinois at Chicago. He finished his graduate work at the University of Maryland and obtained manual therapy certificates from Impact with Jim Meadows. He has co-authored the CRAM Session in Functional Anatomy, a handbook for students and clinicians. Scott is the inventor of Multifidus Muscle Integrator, MMI, and the Versatile Outdoor Core Trainer. He has taught continuing education courses nationally and internationally, with his areas of interest being biomechanics of the spine, sacroiliac joint, manual therapy, and rehabilitation. He has been practicing since 1989. And now, please welcome Scott.
Hello, everybody. Thanks for coming to the webinar. And we're going to go over, this is by no means a full course that we're going to go over every technique, but this is just to give you an idea of what to do with your patients that have issues with fall prevention and balance, and how does manual therapy really integrate into that type of treatment regime, and also what exercises are important for these type of patients. And if you do see these cases already, you might be familiar with some of these techniques, and might be familiar with some of the testing. Let's begin with a case study, and the case study is a 48-year-old female, and she's got some head issues where she has some dizziness, but it's an unevenness. In other words, if you have patients that come in with disequilibrium, the nice thing about that is you can determine whether or not what type of dizziness they have, which there's three types, where you have your vertigo, which is your true vertigo, you have your disequilibrium, and you also have your lightheadedness or your problems with what we call presyncope, which is where it's more of a dizziness, lightheadedness combination. Disequilibrium a lot of times can come from the neck itself, and especially with patients that are arthritic. So this particular case, no dizziness, no vertigo, a little bit of dizziness, but no vertigo, and also she slept funny, and she had some previous stress that created lifting objects. As far as the objective data with this case, you have situations where she has pain in the left side of her neck and down left side of her spine by the shoulder blade and into the upper trap. So when we look at things like what reflexes are involved or how is the vestibular spinal reflex affected, remember the vestibular spinal reflex is affected with VOR, and what's important about that is it usually works through their eyes. So when you have somebody that has disequilibrium, be real cognizant in your mind to look at the upper cervical spine, meaning the OA joint, C1, C2. And it's very important to remember that with those two combined joints, as they move together in a very synchronistic pattern, you have problems with either rotation or actually translation of C1 right or left. So be real concerned about that when you look at these people. Again, a little bit of anatomy to be concerned about. If you look at the picture in the middle of the page, we have your upper trap, levator scapula, semispinalis capitis. You also have rhomboids. All these parascapular muscles and suboccipital muscles, not the deep ones per se in this situation, can be affected, and you just want to make sure that you assess these when you go through your scanning exam. The other things, too, as far as the posterior muscles, is, as we've all heard about the very deep muscles in the neck, we have the rectus capitis posterior minor and the major, and the oblique capitis inferior and the superior. And this is more like a tent. I always look at this as a tenting system here with the tentorium membrane, but also you have these nice attachment points, and you can see where they do attach to the skull. They can give pain. Can they give you dizziness? They can contribute, especially if the neck is out of place. And that's why I emphasize in this case, make sure you look at the upper cervical, and in your patients that come in and say they're kind of like a teeter-totter, they're walking kind of drunk, non-drinkers, of course. But what they do is they have issues because of the fact that they have trouble with certain movements. As far as other muscles, the SCM, as we all know, with rotation to one side, side bending as well, semispinalis capitis, all these can be affected. Spinalis thoracis, and the thing about these muscles, they integrate and they interdigitate together with the multifidus, with the upper trap, levator scapulus. So they're all involved, and you definitely want to just check them out and see which ones can be affected with certain cases. This picture is kind of interesting, and I made this one upside down just so you can see the tent where you can see the oblique capitis superior really grabbing up on the occipital bone, and it can be affected. If one side's tighter than the other, it can definitely pull that occipital bone. If anybody out there is versed in cranial sacral therapy, you can find that this area will be affected a lot. And if one side of the occiput is being pulled more than the other side, the thing about this is it will definitely affect the cranial motion of the head. Now, can cranial motion affect a person's disequilibrium? It can. And if anyone out there has studied cranial sacral, you'll find that if you fix the vertebra and you fix the upper lower cervical and the cranial system, these kind of patients do a lot better. And again, different muscles, rotator cuff. And why are these important? These are important because, and in my world, what I do a lot of is these kind of patients, in this particular case, we're going to strengthen the suboccipital muscles. We're going to strengthen the deep cervicals. We're going to strengthen the rotator cuff, the posterior suboccipital, also the rhomboids, lats. The reason we do that is because you want to pull the shoulders back, create a change in the muscle imbalances. These are cases, people are 60, 70 years old usually, and they come in, and if they're a female, for example, used to sewing, their head is forward, they have poor posture, it creates a problem with the vestibular ocular reflex to the cerebellum, which then controls motion, muscle coordination, and motor learning. If, in fact, that's the case, what's going to happen is you lose control of those muscles and the ability for them to work correctly. You want to retrain that. So, again, that's why these pictures are just to kind of remind you as well. A couple things also to look at, and with disequilibrium cases, many times besides the upper cervical, check the first and second ribs. These are usually elevated, and on the side that they say that they have more pain on, usually they're elevated, and usually you can feel them directly. You can see them usually on one side versus the other. If you go right through the upper trap, you can feel the bone sticking up superiorly. And you want to manipulate that and put that back in. A lot of times when you do that with a manipulation to the upper cervical spine, they do get better, and they can get better. Now, before any, and I suggest this to the folks out there, before any type of manipulation to the cervical spine, especially with somebody that has osteopenia, that has a history of RA, has a history of ankylosing spondylitis, or any type of spondyloarthropathy, you really need to do sharp purser exam, C1, C2 shear, Hoffman sign, iliac ligament. And the reason you do these is to protect you, to say that you've cleared the upper cervical and also you've cleared the iliac ligament, which controls side bending and so forth for the DEN C2 and C2 motion from having any issues. If somebody comes in, they have disequilibrium or dizziness, and they've been in a car accident, you must check these. It's very imperative. Sharp purser is probably one of the most tested tests, and actually specificity-wise will test the transverse ligament. And that's very important, as we all know, because it controls DEN motion, which is going to be very intricate with the spinal cord. So if, in fact, the person has had a motor vehicle accident and they're coming in saying, hey, I'm dizzy and I'm also lightheaded, those are red flags. Got to be very, very careful not to manipulate those folks. The reason is because most physicians don't do these tests unless they're versed in manual therapy like DOs. And the way you want to make sure that you clear this stuff because of the fact that it's going to protect you as a therapist. You just jot it down, these were negative or whatever else, and that way you can determine if, in fact, the person is cleared. So say they are, and you want to manipulate C1, C2, check the occiput for motion, and then you also go through as well lower cervical on your screen exam. But this is all part of when you're doing your basic screen before you do your biomechanical examination. So as we move on, C1, C2 shear is just to make sure that there's no issue with as you stabilize C2, you put your hand on C1, the lateral mass, you're literally shearing one against the other. And you want to see if there's any issues with movement, clunking, movement, instability, numbness, tingling, signs that there could be something going on with nerve. It could be something going on with the spinal cord where you might be creating pinching. In those cases, once again, you don't want to be doing any type of manipulation on those types of patients. Hoffman sign. This is actually like a Babinski for the upper quarter and the upper extremity. What you're doing is you're flicking the nail bed of the third finger, and you're determining if they do a flex or withdrawal. And that is a concern because that is a pure cord compression issue. If, in fact, the person does have that, then it's a quick ride to the doc, and they have to be checked out for any cord compression. That means you don't manipulate. Now, lower cervical spine, C3 to C7. Again, you're looking at a number of things here. Someone who comes into your clinic that does have, dizziness per se or lightheadedness on the script, you want to check, and they come in, they say, I'm more off balance, like I'm more teeter-totter. They come in, they don't have BPPV, they don't have issues with falling per se, but they do have trouble with balance and control. Well, these cases, a lot of them, because if they're arthritic, they could have trouble with the U joints or the Z system, meaning the zygomatic joints, and the U joints are the joints that help you with side bending, whereas Z joints will help you with the translation from left to right, right to left. Well, as we all know, as far as manual therapy is concerned, if in fact you have somebody that does have, say, a joint that's stuck in flexion and they can't go into extension, if you have multiple segments in a group rotation or a group of joints that are stuck, you're not going to be able to have good motion. That can create compression. If they do have arthritis in their neck, then that can create some compression, even a little bit on the nerve, and it can create a problem. If they do have trouble with a zygomatic joint on the left, they could still have side bending restriction on the right, and you want to check the U joint to do that. So again, these are just things to kind of remind yourself, don't neglect those joints, and you want to look at the ability to see how they move. Now, as far as this next slide, number 12, you can see the right I put in here how this kind of works together with the deep suboccipital muscles, kind of like a little tent system with your rectus capices, oblique capus superior and inferior, and the two little dots are the bifid spines, C2, to kind of give you an idea. Don't neglect those muscles. Only problem you'll have with these cases, people can get occipital neuritis, which can give them dizziness through this area. So if you notice that if you push too hard, they get tingling numbness up the back of their head. That goes directly to their ear as you're stretching out the suboccips. Then that's something to note and to let the docs know, because sometimes they do have to inject those, especially if there's some trauma related to the issue at hand and the issue that might have occurred that caused the dizziness. And again, just to remind everybody that as far as anterior posterior for C1 and C2, we have on the right, we have the den sticking up, and you have the occipital condyles to the left. And just remember that when you're dealing with a lot of these disequilibrium cases, you do have trouble with the upper cervical spine, where they have trouble with usually flexion, usually on one side versus the other, so the posterior glide is not going to be very prevalent on that side. What you also will notice is if you attempt to translate C1, say from left to right, and the right portion of the occipital bone is not translating posteriorly on that side, that means that C1 cannot translate to the right because the bone is stuck in flexion, or stuck in extension, or anterior. So you need to manipulate it to move it back into place. Can this give you a problem with dizziness? It can, but it also gives you trouble with turning your head to the right, and it can also give you trouble with, say, looking out when you're driving. Patients will tell you, they come in and say, you know what, if I turn my head to the right, I feel this dizziness thing going on. It's new, I slept funny, I picked something up, I bumped my head. All those things can create these problems. So don't neglect these type of joint checks. So you check the actual biomechanics of that level. As we go forward and we look at, we move forward for the different. We talked about C1, C2. The bottom line is be careful with when you manipulate C1, C2. Don't neglect the lower cervical, because that's going to work hand in hand. C1, C2 works as a kind of like a biconvex system where you have shoulders on top of each other and you have convex and convex, so it isn't like a convex concave system as well. But the key is to make sure that once you clear and fix C1, C2 and the rotation is better, flex extension is better as well, then you can go to the lower cervical. But I wouldn't go from lower to upper, go from upper to lower, and then also fix the first ribs, and then you can see if the dizziness is better. A lot of times the dizziness is not related to BPPV. But if, in fact, the person comes in and they do have trouble with turning to the right or turning to the left, then what they're going to do is they could have a problem with the vestibular system as far as the bony labyrinth, and that's more of dealing with BPPV. As we all know, if you do Hall-Pike-Dix and you do get a specific positive, if you have sit at the edge of the bed, you turn their head 45 degrees, and then you lay them down with their head off the edge of the bed, or what you do is you go 45 degrees and just lay them straight down the table. If they do get dizziness, and even without nystagmus, you'll get a positive sign for BPPV, say, to the right. If, in fact, that's the case, you're dealing with the horizontal canals usually. If they come in and they do say that they get dizziness when they go up and down, meaning if they move their head up and down in that anterior-posterior motion versus side to side, that's more of the superior anterior canal. And that's, again, you're still dealing with crystals. You're still dealing with that portion of the vestibular system. You have two systems that can create a disequilibrium or dizziness situation with the ear. And again, you have the sound system, which is going to create a problem because if they have trouble with hearing, that's going to affect the organ of Corti. But if you have, on the other hand, a problem with the concha or the crystals, the problem with that is you're going to have trouble with that as well if they turn a head to the right, to the left, or up and down. So both systems can be affected. And if you have patients that come in and they're older and they say, we're hearing aids, when they put those hearing aids in, they have a tendency to jam that in their ear. When they do that, they actually jam the temporal bone into their head, which actually what it does is it messes with the greater ring of the sphenoid and also the pterygoids. The problem with that, when you have that problem and they do jam in those hearing aids, that can create a dizziness problem as well. So you want to definitely look at how, if they have hearing aids, you got to look at, if anyone does craniosacral, you want to look at the actual temporal motion of the actual bone, of the temporal bone. The temporal bone will actually move into external. It will actually rotate into the rotate. And if anyone out there does cranial, they understand how, as a person breathes, takes a big breath in, the actual temporal bones will externally rotate, or they actually move away from their head. If that's not occurring, that's going to create a problem within their ear, and that can create a lot of times some dizziness issues. But the big thing to remember here, as we move along, if the person comes in, they do have positive BPPV, the epi procedure does work well. But don't forget as well, as far as the hearing system, if in fact they do have trouble with hearing, at the same time they get positional BPPV in a sense, you definitely want to do the epi. You want to correct the actual otolymph issues and the crystal issues, but at the same time they're having trouble with the organ of Corti, and they're having trouble with the cochlea, and they're having trouble with transmission of sound. Which, what you need to do with those cases, because sometimes these people just can't hear very well, and as they get older, they lose that part on one side or the other. So what you do is you do a lot of balance activities with them, or say they stand on foam and they scan their eyes, or they use a machine like a Bowdix balance machine, or you get them on a ball and you have them do different activities on a ball, where say they lift their leg up, they scan their eyes, do that kind of thing, all those kind of activities. Because if you do that, you're challenging their vestibular system, and what you're theoretically doing is you're over-challenging the systems that they still have to compensate for the systems they don't, or systems that are not efficient, which means in their case it's the hearing system. So again, as sound comes in, and the key is to understand that as the sound travels, it's going to go through the oval window first. It creates a sound chamber activity where it will go all the way through the organ of Corti, goes through the cochlea, and that goes back out through the round window in a very quick fashion. But if that system is affected, it will create a problem. You have a young person that comes in with a tympanic membrane or eardrum issue. This whole system is affected in the same way. Even though they're younger, it doesn't mean they can't have an issue, as we all know. So in these cases, you want to be careful of stick anything in their ears, especially Q-tips or whatever. But in the cases of concussions and sports injuries and things like that, these cases can also have an issue where, because their hearing can be affected and they can't affect their balance, it's very important to retrain that. So the bottom line is train both systems, and if one system is affected, you pretty much overcompensate with the other one. Now in this case, the person has 3-week symptoms, right lower neck is affected, minimal or moderate referral. Okay. So 48 years old, turning your head to the right is restricted, side bending to the right, and quadrant patterns. And if people out there are familiar with quadrant patterns of movement, the neck works in quadrant patterns just like most of the other joints, where if you do extension rotation to the right, flexion rotation left, extension rotation to the left, flexion rotation right. So you're getting different quadrants of motion. The reason you do that is because you want to go ahead and you want to gather information in this crossing pattern to approximate the joint, to see what the joint end feel is telling you. So if you take somebody back, side bending to the right, and back into extension on the right, and they can't do that, and they're having trouble with that, a lot of times those segments are stuck in that region, or there is a segment that's stuck, and this is what you do in your scanning exam before you do any specific biomechanical test to go ahead and determine what level you might want to manipulate or what level you might want to focus on. So in this case, activities that are affected driving. Now, what's your subjective questions? Things like, for example, what did you do, or what kind of referral is it? Do you have burning pain? Do you have lancinating pain? Patient says, no, I have no lancinating pain down my arm. I have no burning pain down my arm. I have pain when I turn my head to the right. I have pain when I go ahead and want to look out, when I'm driving. So the next question will be, which is very important, if you sit at rest, does it bother you? No, it doesn't. It only hurts in those specific situations. Sleeping is affected minimally, only if I turn my head that way. So the reason you do this is you want to make sure that you rule out differentials. So if you look at some differentials in this case, and the way I usually do it is where I have a whiteboard, and I determine, based on what they're telling me, what are my differentials. Could this be a ligament tear? Well, was there an injury? No, not really. Disc issue. Well, with a disc issue, per se, in the neck, and remember the disc in the cervical spine after 25 becomes 1, so it's not truly a nucleus pulposus with annular fibrosis. It's not that way. It's one specific clump of material. Now, it can rupture. Yes, it can. It can definitely do that, but in this case, there's really no referral. There's no burning. There's no lancinating pain. There's some neck pain, but it's only based on movement. Fracture, no injury, no reason for a fracture. As far as the differential is concerned, though, if they came into you and they did have very specific immediate severe onset of pain, so they're a football player, get an injury, immediate severe onset of pain, they come into your office, that's a person you definitely don't want to be stretching and manipulate. Usually in those cases they have very little motion, they lose immediate motion as well. So those are people you send in a collar and you send them back to the doc. Spondylolisthesis. One bone is relatively forward compared to the other bone in, say, C4 and C5 or C5 and C6. And again, the problem in this situation is you could feel for that, but yes, this could give a person achiness in the back of their shoulder blade. It's more common in the lumbar spine than in the cervical spine, but it still does occur. Arthritis can happen 2 ways. They can be older, where they get just basic osteoarthritis, or they could have a post-traumatic arthritis if there was an injury. Post-traumatic arthritic changes usually do occur, maybe a couple days later to a week later, but they are prevalent and they can create less motion in the neck, and they also can create a lot of problems down the road with, say, dizziness or disequilibrium or balance issues, because of the fact that if they do have any arthritis, the arthritic change just kind of escalates, and it does create a problem. Segmental dysfunction. What this is more, and if you've never heard this term before, segmental dysfunction is where the segment is put into the wrong position, or something has created a segmental change, where the person's not able to flex very well, extend very well, side bend very well, whatever it might be, and this can create a problem. What do they feel? They feel a nice minimum to moderate referral. Sometimes they can have, along with segmental dysfunction as a diagnosis, you can have what we call segmental facilitation. Segmental facilitation is very specific to where the segment's out of place and it creates weakness in a muscle group, in a myotome group. And that's something that is very important to recognize when you're evaluating these patients, because if you fix the segment, a lot of times the weakness can go away. And that leads us to the weakness wheel, as I call it, because these are all neurophysiological weaknesses that do occur with the majority of cervical cases that do have either disequilibrium problems or dizziness or just weakness in general. A lot of the older cases, 50, 60, 70-year-old people, they do have trouble with this kind of stuff. And segmental facilitation is different from axoplasmic flow, which is different than reflex inhibition or pain inhibition. So if somebody comes in, they say, I have pain in my neck, and I've had this for a number of months, a number of weeks, what do I do? And you evaluate them, and you find that they're weak, say it's C5 myotome, but they didn't really do anything. They have no recollection of any injury at all. They have no recollection of any problems, but they do show weakness. The concern you have is why. So remember, a myotome, as mentioned here, is a muscle or a group of muscles that are attached to a specific nerve. So if you notice in your exam that C4-5 or C5-6, they're affected, you know that's going to be innervating the myotomes at C5 and C6 for muscles of rotator cuff, abductors, bicep, forearm muscles as well. And if you notice in your exam that they are weaker, you're putting your puzzle pieces together where you're noticing that, okay, this area is affected. So what is that segment doing? You do a biomechanical examination, you determine that it's either flexed or extended, they got some U-joint problems, you put all this stuff back together, and the person gets stronger instantly. Well, that tells you that they did definitely have a segmental dysfunction, but they also had segmental facilitation. It's coming from a segment. It's coming from a specific area. It's coming from the neck at that level. But also the determining factor with this is with segmental facilitation, you're going to find that the person has weakness, but is just weak compared to the other side. Now, this is different from what we call axoplasmic flow, which is a very different type of system because it's neurologically based on the microtubules, where you have what we call slower fast flow compromise, which is really going to affect the ability of the muscle to fire over time, which means it's going to fatigue very quickly. What you notice in your exam is if a person comes in, say C6, their wrist extensors, and they're just fatiguing. You test them once, they're not bad. You test them more, 2-3 times, you notice that they're getting more fatigued, and they can't really move very well because of the fact that the muscles aren't working. That could be more axoplasmic flow issues, and that can come from the neck. But it's because the compression or torsion of the nerve, for some reason, has created a problem. The person that slept funny, the person that played football and stretched out their brachial plexus, those are great people to have this axoplasmic flow problem. It's cool for us to see, not good for them, because it takes a little while for this to reverse itself to come back, especially with nutrition. If you've ever had cases where the rotator cuff on the insertion points are painful, bicep is as well. If you have trouble, if you see these cases where for some reason those points are tender and they're sore and they have problems and they're weak, that's not because that they did anything. A lot of times, if in fact the tendon has been overworked because of poor, just because of poor segmental control, poor neurological control. The problem is that when the tendon is overworked, it has poor nutrition coming from the nerve, and what that does, it makes the attachment site sore. So when you fix the segment and you fix the areas around that area, besides working on it locally at the insertion points, then you'll notice that the problem is they totally have too much weakness in that area, and then once you fix that, they do get better. But again, the question becomes, why do they have it? So again, we got to look at what they do. As far as pain inhibition, again, pretty self-explanatory. If the person has pain when you test them strength, whether it's their neck or if you test their shoulder, whatever it is at the myotome level, if they have pain inhibition, as soon as you test them, they'll say, ow, and it hurts, and it's inhibited because of pain, because of either a tear in the muscle, tear in the ligament, or a tear in the capsule. But again, bottom line is their muscular system is not working. So again, that type of weakness is pretty sudden. So in other words, segmental facilitation, it's just going to be weaker, so it's not going to just fall off. Fatigability is going to be axoplasmic flow. Pain inhibition is going to be a very quick, because it's like, ow, and they stop. Where reflex inhibition is more of a breaking, where the person can hold a little bit and all of a sudden, boom, they lose it. And what happens with that, that's a local phenomenon around the joint, which means that if you're checking the shoulder C5 rotator cuff and you actually push and you have them hold it, what you're going to find is that these people will have weakness. But if you wobble the joint, meaning you say you take their arm and you move it up and down, and you get some proprioception back in that joint from the mechanoreceptors, what happens is they get stronger immediately. If, in fact, you can improve on that, then what you do is you check their neck as well, and you can actually decrease the segmental dysfunction, which is creating the segmental facilitation around C5 myotome, but you also improve the joint integrity in the mechanoreceptors, which increases the strength at the local level by actually doing all these. So again, these are things you can do in your assessment. And again, with these people that have problems with weakness, these muscle systems are important because of the fact that the neurological weakness that occurs can affect them in a variety of ways. The problem is if you don't understand and you don't get all these muscles stronger, then their balances are there. It continues to work on their neck, continues to give them a problem. It continues to give them this disequilibrium, and actually it gives them poor confidence because then they have trouble with falling and trouble with other issues as well. So again, if the person comes in and specific questions, any pain with motions or pain in the head or in the shoulder blade, or when you're dealing with pain and the person comes in and says they have pain in their neck that goes down to their shoulder, again, be very specific on how you ask your questions. If you move your shoulder, does it hurt? Does it hurt your neck? No. If I move my head, does it hurt my shoulder? Well, it does if I side bend this way. It does give me pain down my arm. So again, what you're determining is where is it coming from? Where is this specifically coming from? Where is the pain being generated? And it's important to remember that. So this table is just a quick table for you to have as far as the ability to know the differences between the weaknesses and the facilitations and also axoplasmic flow. And again, as we discussed with the upper cervical spine affect balance and proprioception, just threw one article in there for you. It does affect it, and they said this article showed that with stroke cases and really any case that proprioceptor neurological facilitation patterns work great with the neck, but also it's very important because in this particular case, it's important because they integrated a whole bunch of different systems with PNF, and the upper cervical spine was affected. Now, the cervicocollic reflex, and the reason I brought this up is because it's a reflex that a lot of folks aren't familiar with, but also besides your vestibular ocular reflex, your cervicocollic reflex is a reflex that comes from the segments in your neck. And if, in fact, the neck's in the wrong position, the electrical activity to the muscles and the dorsal muscles in your neck and down that attach to your cervical spine, but also to your occipital bone, are affected. So if, in fact, the cervical levels, lower cervical, 3, 4, 5, 5, 1, all that kind of stuff are affected where you are affected, but you put them in place, and especially C5, C6, C6, C7, this reflex is actually heightened. And the good thing about this is this will work very, very well with the vestibular ocular reflex. Because if the vestibular ocular reflex is affected where the person has trouble with balance and control and muscular control, these two systems work together. So to have somebody stand on, say, a BAPS board, which would be a pretty high level for some folks, and they scan their eyes back and forth, you're truly working the cerebellum, motor control, motor learning, with the vestibular collic reflex and also with the vestibular ocular reflex. And remember that the VOS will work in concert with the vestibular spinal reflex, which is going to help the person not fall over as they move their head from side to side. So it's important to remember that it can't be just a person comes in with dizziness, oh, you got an ear problem. Not true. A lot of times it's the cervical thoracic spine need to be looked at. They need to be actually really, really identified at what levels are affected, what are the ribs doing, how is this being affected, how is this affecting the whole system. Because if, in fact, you do have a problem with segmental facilitation or dysfunction, the problem is, remember, T5 is going to affect up into the cervical spine. T5 is going to affect down into, T8 because the signal changes. Okay, so the key is how are you going to determine that, and that's going to be determined by your examination. Now, in this case, we have a 14-year-old soccer player hitting the head, turning her head forcibly to the left. What does she have? Headaches, Turning her head to the left is painful, promotes disequilibrium, side bending her head to the left, and translation to the left is affected. And again, cervical flexion is affected as well on the left side. Now, in this case, again, you want to get as much information as you can, okay? You want to get as much info as you possibly can, so you'll be able to go ahead and determine the best course for these patients. In this case, what is the diagnosis? What's the differential diagnosis? Okay, so did this person have a concussion? Did she have concussion testing? And again, a lot of times they go through protocols now compared to what they used to. Muscle control. If, in fact, when you do your exam, in this case, you definitely want to do a cranial nerve exam where you make sure the cranial nerves are all working. You want to make sure specifically cranial nerves 3, 4, and 6 are working properly, and those are linked to eye scanning. The oculomotor, trochlear, and abducens nerves will affect eye scanning from side to side. So, again, if you stand in front of the person and you scan their eyes, back. Someone's telling me that it's. Hang on, I'll go back to speaker. But can everybody hear me now on speaker? Robin, is that better on speaker?
That's better, thank you.
Okay. So if you stand in front of the person and you scan their eyes, you'll determine that say, for example, in this case, the left eye might not scan side to side as well as up and down or going to the right. So here's the problem. If in fact that's the case, that's a tip for you guys to cue into the upper cervical spine, cue into the cranial system, because those will definitely be affected with somebody that hit their head. Then you go to the lower cervical spine, okay, and you check and make sure that all those segments are working properly. And if they are working properly, then, or not, you fix them, and if they're working properly, then go to your muscle systems. Because if you don't and you only do one thing, you're going to miss out on being able to help this type of case. So just so everybody understands it, it's important to go ahead and review all the different portions of the upper lower cervical as well as the cranial nerve system in this situation, so you can determine if in fact there is a problem. Because you can pick something up subtlety, but again, if somebody gets hit in the head, you want to be real careful. Also, make sure you check with these folks, did they have immediate threats of the pain? If they didn't get hit in the head, whatever else, then it's more of a problem with direct trauma. Okay. All right. Now let's move on here. All right, so we mentioned the reflexes as well, as far as the ability to just test them, and just be real cognizant of the fact that the vestibular spinal reflex and the vestibular ocular reflex, those two reflexes work hand in hand. So if you for example side bend to the left with your trunk, the vestibular spinal reflex is going to help you prevent with the anti-gravity muscles you from falling over, but at the same time the VOR is going to help you with in fact moving your eyes to the opposite side so you don't fall over. What's also very interesting about the way we're made is that if you turn your head to the left, for example, the left semicircular canal is going to be turned on, but the right semicircular canal is going to be turned off. What also occurs is the medial rectus muscle is going to be turned on the left eye, where the lateral rectus muscle is going to be turned on the right. So you have these systems where, for check and balance. So when you test somebody's eyes and you scan them back and forth, what's going to happen is you're going to pick up subtleties with them as far as the ability to know what side's affected more. Cue right into that side, check their cervical spine, upper, lower, check their first ribs, check their muscle. Once you put that together and you start fixing those things, then you can cue into the muscular system and you can just work on all those muscle imbalances. This will help usually for all cases where you have disequilibrium, where you have problems with those cases as well. Now, okay, so we talked about segmental facilitation, how it does affect the muscles, and again, the bottom line is what you want to be careful of when you're doing rehab. Make sure after you fix segments, after you fix lower cervical in this case, go back and recheck the muscle strength. If it's better right away, you know you're getting something more from the cervical spine that could be affecting that muscular tissue. If, in fact, you do check them and they're not any better, that could be coming more so from, say, the shoulder or some cases even down the arm. So you want to make sure that you kind of determine where is the cause coming from as well. Now, again, with BPPV, as we discussed, do Hall-Pike Dix. If this person did come in and they have a problem with dizziness and lightheadedness, then you're dealing with something totally different where you need to be concerned with more VBI, which is the vertebral artery could be pinched. Somebody's in a motor vehicle accident, hit their head in soccer, hockey player, football player. Those cases have to be very carefully checked to make sure that you're not dealing with any VBI symptoms. So if you do, we call a declines test, or you do a modified declines where their head's not off the edge of the bed, or you do a reproduction exam where you put their head into a rotated position and you look at their eyes, you check for nystagmus, you check for any type of problems with speaking, have them count backwards from 15, check both sides. Those cases, if you suspect that, especially in those situations, those are definite. Go back to the doctor, and you got a big issue going on. But those are far and few between. You don't see a lot of those. You see more usually the disequilibriums with I'm lightheaded, or I look down at the shelf at the grocery store, I stand up and I lose my balance. Or what happens is they get a little dizzy. It comes back in about 30 seconds, and which is great. And that's all. That's not like a BPV issue at all. Just so you know, they don't need an epi procedure. They need more of standing up slower is what they need. But also what you want to do is you want to understand that in this schematic, as I showed you in these couple slides, this red slide will show you, say, T6. If that's affected, that is going to affect T4, T8. It's going to affect you up the chain to affect all the way up to the cervical spine. So, person that comes in, cervical problems, okay, and dysfunction and or disequilibrium, don't neglect the thoracic spine. The reason is you want to make sure and you want to clear the thoracic spine, and if you do, go ahead and find something, you want to fix it. Rib dysfunctions, segmental dysfunctions in that area, because these areas can also give you segmental facilitation and dysfunctions that create weakness in the upper quarter on the affected side. And again, the biggest thing is remember how everything communicates, okay? Rehabilitation, as far as prevention goes, what's important? And again, you want to kind of work on it. What I do is I work on activities that combine neurophysiological control with exercise. So I'll have them do a straight leg raise and scan their eyes. I'll have them do bridging and scan their eyes. I'll have them stand on foam and then touch their nose. And we've probably all done stuff like that. Or I use a Biotics balance machine, or I use other machines that kind of coordinate using muscle, but at the same time, what I do is I use their eyes, through their eyes, to tap into their cerebellum in order to get them to get the muscles to work better and get the motor learning better. As we all know, the key to these cases, especially when they're older, to prevent falling, is you want to practice as perfect as possible to get them to have better motor planning and motor learning. So is rehabilitation important? Yes. Is it important to have a person that has fall issues to work on their hips? Absolutely. If they come in with a cervical script, you work on their hips? I would. Again, in these days of direct access, I think it's important to go ahead and work on those areas because, again, that all helps with fall prevention. So with those cases, if they come in and they do have trouble with dizziness, disequilibrium, yeah, work on the hips, the trunk control, the core muscles, pelvic floor, and then work your way up. Lats, levator scapula, deep suboccipital muscles, all that. Cervical flexors are usually very weak on these cases. If the cervical flexors are weak, the problem you're going to have is a lot of times it can have those segments slide forward. That can create a problem. If that's the case, you will have a problem with stability, not necessarily instability, but you'll have a problem with stability to those levels. True instability, as we all know, is with ligamentous disruption, and you need to do. That's why it's important to do those tests to the lumbar, to the cervical spine, in order to determine if they do have any issues like that at all. Because as we all know, people forget to tell you in their history what's really going on. So again, prevention, rehabilitation for osteoporosis, all these things are important, and muscle strengthening for fall prevention. So In the next couple slides, I gave you just some different stretches and things you can do to stretch biceps. You can do joint mobilization and things like that to stretch out these areas to help these folks. Okay, so different ways to do different things, and of course you're welcome to have all these slides, shoulder blade, and we've all done a lot of these. These activities are just basic scap work. Okay, so 6s, 5s, and 7s, all this kind of stuff that you can do to strengthen, stretch out, your cervical cases, and also your disequilibrium cases as well. So how do we integrate this into a nice little package? Well, the thing is this: people, as we all know, change postures and positions, and they move from one area to another. They're not always going to be in a static position where they're going to be, washing dishes or whatever else. I mean, they vacuum, they lift things, they do whatever. So the key is, in your practices, if you can integrate a nice biomechanical package where you do your scan exam, you determine what's going on, you do your PIVM, your PAVMs, which in other words you're looking at segmental motion. PAVMs, you're determining what segment's actually affected in a biomechanical way, and if in fact you have issues with one level, you fix that level. Fix upper cervical, lower cervical, first rib, thoracic. Get that all happy. Make sure they're good. Make sure things are moving correctly. Then you work on your strengthening systems. You work on your upper traps, levators, your scap muscles, your lower back, your trunk, your core. Once you do that, then what I would do is challenge them where, if you have upper bikes at your clinic, have them stand on foam while they do it. So, or a BOSU board. So they're challenging the system very succinctly while they're doing another activity. And if you can integrate different activities you would normally do, like bicep curls or triceps or whatever, but you integrate that while they have to stand on foam or they have to scan their eyes back and forth while they're doing this, you'll find it's twice as hard for these people. Or you have them spread their feet apart or stagger while they're actually going ahead and doing the activity. So again, what I like to do is challenge them and challenge their trunk and challenge them while they're actually doing these activities. Now this case is interesting because this is a case where a person has right-sided pain down their hip. They have posterior pain, side of their leg, they're a runner. When they turn in bed, it's bad. Pain description is achy, not shooting, as mentioned. Fortin's finger sign is positive. So again, in this case, why is this important? I mean, we're talking about cervical, but I threw in a lumbar case. The reason I did that is because the lumbar spine is very intricate to balance and control. This case, if anybody recognizes Fortin's finger sign, and that's very indicative of SI dysfunction. SI dysfunction, the person usually states that they have pain when they turn in bed, they have pain the first few steps, they feel better as they walk more, but when they sit they get stiff and achy, and when they attempt to turn they have pain. The problem in this case is if in fact this is out of place and they're walking funny, what they do is they destabilize their hip, they destabilize the SI joint, lumbar spine, and that can create a problem with motion. Also what it can create is a problem with their femoral head. So if the femoral head in these cases, what happens is it usually moves like in an anteromedial position, so it's stuck forward, and you need to put that back in place. Not necessarily putting the SI joint back in place. If you fix the lumbar spine, a lot of times in these cases the SI joint will follow, and you don't have to mess with the SI joint. What's also affected here? Well, the iliosacral joint will usually have an upslip on the side that's affected. If the iliosacral joint is affected in any of your cases, and whether it's back or neck, whatever it is, okay, and they do have balance problems. Now, I'm not talking about if they just come with cervical pain, but if they do have balance issues and they do have trouble with specific problems dealing with disequilibrium, or they come in and say, I keep falling over, I'm not sure what's going on. Well, if you check their hip and you check the iliosacral joint, you can find that that's elevated on the side that's affected. You fix that, you go ahead and you fix their pelvis, you fix their lumbar spine, make sure their neck is fine. You'll find a lot of these cases get better, and they get better very quickly. And they get better because you've totally reestablished the neurological system in the upper lower quarter. Once you do that, though, remember, these people need functional exercise, PNF patterns, trunk PNF patterns. Get them on a ball. Have them shimmy side to side on a ball. Have them do it with machines where they're working arms and legs at the same time, but they're also working their eyes. Have them go on the upper bike and scan their eyes. Have them go on the upper bike and turn their head from side to side. All these interesting integrative activities, unless they have specific BPPV, so they don't have to turn their head that quickly. But the bottom line is what you're doing is you're integrating the vestibular system with other systems, neurological with orthopedic. And once you do that, you find these people get better faster. Rehab takes a little bit longer here. It's not a 40-minute deal for these patients. It could be an hour and a half. But they do wind up doing better. Multifidus, lumbar multifidus is one of the most important muscles in the lumbar spine, as we all know, and if we don't work it, we don't train it, we don't train the hips and the glutes, and we don't train them in a proper way, they do not get better. It's very important that you go ahead and you train this muscle system in a very integrative way, and you train it in a functional way, but you also isolate it with the glutes and also with sling patterns. If folks are familiar with sling patterns, where you're working, say, left arm and right leg, left arm knee bent on the right, you're actually gaining a lot of strength crossing the spine. Once you do that, then you'll find that they can get stronger faster, and you're integrating a crossing pattern, so you're actually working the strength system in the fascial line plane system, which is really efficient because you're actually pulling the muscles as they need to go along the diagonal patterns. These kind of patients do real well with this type of training. And again, these different ligaments I've pointed out, these are all very important as far as stability is concerned. Lumbar multifidus is mentioned, but these ligament stability areas like iliolumbar ligament, it actually provides a reflex to the multifidus, which can either turn it on or off. So if, in fact, that the multifidus is inhibited and it has some reflex inhibition locally, once you do some CPA glides on that segment and it comes back, hopefully, the important part is to make sure that they have not had any trauma to these areas, because that means the iliolumbar ligament or the dorsosacroiliac ligaments in the pelvis can be actually stretched or weakened, and there's some laxity within those. So, again, trunk pelvic muscle activity is important. It is, because you need to have the support from the pelvis and the trunk, and also way up into the cervical spine. Okay. And again, a different case real quick. Person has soreness in the legs. A little bit older case here, as we discussed earlier, when 65 years old. No lancing pain, mostly achy. Pain is more when this person stands and when she walks versus when she sits. When she sits, she feels better. When she lays down, she feels better, except when she lays on her back. If somebody comes into your office and they say, I have this achy pain. I go up to the bathroom, my legs hurt. I can walk 10 feet. I know we're all thinking about spinal stenosis as a differential, which you're probably very spot on in this case with spinal stenosis with a 65-year-old. If she was 40 years old, I'll be more concerned that it wasn't that, and it could be a spondylolisthesis with those cases because, one, they're not usually in the age group to have that much arthritis unless they've had severe trauma, or trauma from either sports or a car accident or whatever. But in this case, if she says, I lie on my back and it's worse because she's putting her spine in extension. If in fact you went ahead and put this person on their belly and put a pillow under their hips and put them in neutral and they say, it feels better, you're just creating more flexion, as we all know. So bottom line is, in this case, she's got more spinal stenosis. What do you do in this case? One thing you can do with balance cases, whether it's cervical, lumbar, whatever it is, one thing to consider, if you do have any aquatic therapy, I would definitely consider using it, because what that will do is you're challenging the whole balance system in water, and water is a hard thing to master when it's going all different directions. So I put patients in the water and I have them scan their eyes in the water, or have them walk in my pool, turn around in a circle, turn around with their eyes open, one eye closed. So they're challenging that whole neurological system, get the motor learning through the cerebellum working properly. Once you get it working properly, then you can, in my pool, I can turn up current and I can actually generate current, and that helps them. It actually challenges other muscles. So they're working upper lower quarter, upper lower cervical, and again, I'm integrating that nice neurological system with the orthopedic system. And then again, the big thing is make sure that you don't blow off these people when it comes to, checking their neck, checking upper lower cervical, checking even their ribs, shoulders, and you're just doing a good scan, first, second ribs, lumbar spine, pelvis, and see what you have. Because remember, it's not always coming from one area. When you're dealing with the balance or dealing with vestibular or dealing with, neurophysiological weaknesses, what's going on with those? Where's the cause coming from? What segment is it coming from? You're not really sure sometimes, but again, you can sometimes ferret out where it might be coming from, and you can determine the best way to go after it. Okay, as we just mentioned as well, again, with these folks that come in, any head injuries, any trouble with dizziness, true dizziness, where they say, you know what, the room's spinning in a circle, check the cranial nerves. If you any red flags, you know. So the key is if you see somebody come in with like a problem with smiling and frowning, you know, you're looking at facial nerve paralysis possibly. Do they have a problem? Do they wake up that way? You know, so ask those questions. Did you notice that side of your face is drooping relative to the other side? Did you notice that your tongue deviates to one side or the other for hypoglossal? Things like that. And again, if you do notice this stuff and they don't notice it, then you need to tell them, and then they need to be checked out by a physician, or sometimes they got to do different scans, or sometimes they got to do something to create some type of testing so you can determine what's really going on. Because you don't want to be manipulating these people unless you know what's truly going on. All right. Okay, so if one thing too, if you're concerned about how do I do all this, and the thing too is it doesn't take that long to do the assessments, but look at the way you exercise these folks, and look at how long you keep them, and look at what I would do is determine the best way you can do maybe 2 or 3 upper quarter exercises, two or three lower quarter exercises, and there's a couple machines you can use that integrates all this. And the nice thing is, if you utilize those, you'll find, and I have found in my practice, that these patients do get better. And what's interesting is they like certain machines that they can do more than one thing. The reason is because they don't get bored. And I think a lot of times the more we can challenge them and keep their interest up, as we all know, the better they do. The one question I get a lot of is how long do I keep them on different machines? Sometimes I'll keep them on for 15, 20 minutes on one machine. So because you really want to integrate these systems. It takes longer than 100 times to integrate. It takes longer than 3 sets of 20. That doesn't do very much. All that does is teach these folks how to do it, and they have to practice perfectly. Because remember, the cerebellum will pick up if they're practicing incorrectly. If they practice correctly, the cerebellum will pick up perfect practice, and they will do a lot better. The problem is if they practice improperly, like for baseball pitchers or whatever it is, they will continue to do it that way because they don't know any different. The University of Michigan did a study one time actually with a number of pitchers, and they had them throw wrong for hundreds and hundreds of times. And they found that when they told them to throw the correct way, they couldn't for a while because they were so used to doing it poorly. So the bottom line is the key to this is practice as strong as you can with these folks to get them to work properly as they possibly can, but then also, if they're doing it wrong, get right on them and make sure they do it correctly. If they say, you know what, I'm still a little dizzy, recheck segments. Always remember, after the initial time of rechecking, after the initial time of manipulation, please go back and check if needed so you can go ahead and determine if something's might have moved out of place again. And when they come in for the next visit, again, they might say, hey, my dizziness is better, but it's still there. Right away, recheck their neck, recheck the uppers, recheck lower cervical. Make sure that everything's in line before the exercise. It's the worst thing you could do to exercise somebody that has segments out of place, things are not in the right position. It just kind of loads everything up in the wrong way, and you don't want to do that. Now, we're kind of running out of time here, but it's always hard not to speak with people directly. So my email is DScPT @gmail.com. So if you have any questions or concerns as far as how to do things, or you want some specific references or whatever else, please, you can email me and ask me questions, whatever you need. But I want to thank everybody for joining today, and thank Robin for the opportunity, and I hope to do this again in the future. Thank you.
Thank you, Scott. We sure appreciate you sharing your expertise and knowledge. We are now going to transition and welcome our fantastic senior product consultant, Kelly Sullivan, who's going to go over some of the equipment that's related to what Scott just talked about.
we're going to talk a little bit about how product relates back to some of the functionality that Scott was talking about. So he was, discussed a lot about manual therapy, but there's a lot of benefit to equipment as well, and how you can utilize equipment for various different conditions and various programs you might have a focus around, as well as capturing data and having that as a measurable outcome for your patient that you're working with. Today, we're going to be focusing on a product line called SMARC, developed by Matrix. There are 8 integrated controlled training products that work to improve functional capability, quality of movement, and cognitive level with an integrated hardware and software combination. This is an electromagnetic system, so the load increases smoothly and proportionately as velocity of movement increases. There is nearly zero inertial force, and resistance is always equal and against movement in counter direction. Some of the potential SMARC applications might include for physical therapy, for example, dual function neuromuscular, which may allow for multiple billing codes. For fitness and wellness, it can help facilitate functional improvements to allow transition to traditional exercise modes like the use of bikes or perhaps treadmills. Fall prevention is another application. These products can challenge the vestibular system and can improve dynamic stability. I'll also mention that the 8 SMARC products that were presented here on the screen and before you can be pulled together in solution packages that answer to various programs such as fall prevention or neurophysiological conditioning or even orthopedic rehabilitation. There are 4 fitness training modes that can be customized to fit the patient's functional ability. So the home page on the equipment allows for the therapist to select the preferred mode. The prescription settings allow for the therapist to customize the training per each mode. Once the training is all set up, goals will be visible to the end user. If you look to the screenshot of the training page, you will see that there is a target range that the therapist can accommodate the user's current state of range of motion, strength, and endurance. The user simply follows the green box that moves up and down within the target range of the prescribed speed and resistance that the therapist set for them. Let's also talk about the 4 fitness training modes now that you see over on the left side of the screen. Velocity control adjusts the resistance between target velocity and actual velocity, and resistance increases 1 level with each repetition. The stretching mode allows for the therapist to set a prescribed hold time and range of motion for that stretch goal. The functional strengthening mode has a controlled target range of movement for elevated stretching, and the active rhythm allows for a cardio program to be incorporated into the routine. Lastly, I wanted to mention the medical mode here. This allows the therapist to create a patient page per user on the SMARC app, which is downloaded onto the therapist's computer, where they can then prescribe the parameters of each machine's activities, and then in turn carries over to the machine with a USB key drive. The therapist and or your physician, if they're setting or prescribing the therapy, can use this mode for reconditioning, syndrome relief, motor learning or relearning for that matter, ADL training, and so on. The focus of today's presentation will be on the ADL package, and this consists of 4 of the 8 SMARC pieces of equipment. This package helps with functional movement needed for daily activities. The equipment works to strengthen the shoulders, the lower back, the trunk, and offer a total body workout. The first machine I'm going to talk to is the SC101 core shoulder machine. This piece of equipment focuses on increasing strength in the shoulder scapula, the elbow, the wrist, and the trunk core muscles. If you notice the images of the gentleman using the machine in the lower right-hand corner of the screen, he is twisting his trunk while engaging in a stretching range of motion activity. The degree of stretch or motion goal can be customized based on the individual's ability. So, for example, if the patient had a rotator cuff surgery recently, their range of motion will be vastly different than a more agile patient. The core shoulder helps encourage the strengthening range needed for daily activities like, for instance, reaching for a glass out of the cabinet. The handles move with the motion so the patient is always in the most optimal ergonomic position with extension of their arm. All SMARC equipment has a wraparound lumbar support, seat position adjustability, and a swivel for added core conditioning when engaged in an activity, and can be locked out if not desired. The CS102 core trunk machine enhances dynamic balance and functional performance with partial weight bearing and one leg standing and stepping, necessary in a multitude of daily functions we engage in on a daily basis. It also features an angle limiter to avoid overstretching and has a multifunction foot platform. Another application is maintaining mobility and symmetric performance of trunk flexion, hip knee flexion, and ankle dorsiflexion. Similar to the core shoulder machine and all SMARC equipment for that matter, it too has a biokinetic seat and features sit-to-rotate function, rotation adjustable seat, front and back height adjustability, and a lumbar support safety pad. Next, we're going to take a look at the SC103 core lower back machine. This product enhances dynamic balance in forward, lateral, and backwards reaching and sitting and standing positioning. It also maintains mobility and symmetric performance of a trunk flexion and lower extremity extension, and enhances functional performance with sit-to-stand, weight shifting and reaching, aerobic performance of upper extremity with rowing training, and also sit-ups. Lastly, we're going to be looking at the SC108 total body machine that enhances coordination and dynamic stability. This product also helps facilitate functional and diagonal movement of the lower extremities and core. Notice the red foot plate at the top of the foot platform. This helps with comfort for those who have conditions that may lead to pain if the foot is forced down onto a flat surface. The total body machine also features a multifunction handlebar and stabilizer handlebar for the upper extremities. And I'll also mention that when Scott was here training me on these pieces of equipment, he did say that this was one of his favorites, so that it was applicable to various different residents and their conditions and has high versatility. So it is a great option if you're looking for a product that focuses on many various different parts of the body and encourages strengthening in several different muscle groups. That is all I have for today. I will mention that those products that you saw on this presentation are here at Direct Supply in our showroom. So if you are here on campus with us at any point in time, feel free to ask your seller that you're partnered with to come by and see the product in person, and I'd be happy to give you a live demo of the equipment. If you have any questions, my contact information is there on the screen. Otherwise, if you're looking for information on pricing, you can always call your account manager. Thanks so much and have a great day.
Thanks, Kelly, and thanks, Scott, both for the great presentations today. If you have any questions about the products discussed, please reach out to Kelly or your account manager. And for more information about upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars. Once again, thank you for attending today.